things just based on questions that have come in, and then I'm going to hand it over and stop talking. So as everyone is aware, we've talked about before, the end to the state of emergency is May 11th. So as of May 12th, we will no longer be under the state of emergency. Now, there still is some efforts / discussions about what additional executive orders may be extended, some timelines that may be directly extended, but the current auspice of the state of emergency will end as of May 12th. The things that have come up that folks are most concerned about, certainly coverage. So we talked before with telemedicine, there is or are legislative actions that would potentially extend, some that may extend it for Medicare Advantage already through 2024. But there are direct actions both within this House and Senate being discussed, both likely to be or potentially a component of budget extensions that may have either permanent or significantly longer extensions of mandates of telehealth parity. But we have heard as recently as I think earlier this week that from the local payers, there is no current plan to back away from the current coverage for telehealth, and that there would still be the commitment that they would give us at least 90 days notice before any change would be implemented. So, we're looking probably no decision before I'd say at least summer, midsummer at this point. So for now, I think everything would continue as business as usual. For the COVID medications, they will go to basically covered share once that state of emergency expires. There's for some of the COVID drugs, of which there's really not a lot other than Paxlovid, and I can never remember the other one. There is some discussion that there may be some EUA that covers it for a period of time, but it'll probably be pretty quick that will go to the patient share under their current insurance arrangement. Similar to be true for testing. So this has come up. What notice should we give patients? What's going to be available for testing? What coverage will be available? There is not a one size fits all. So I think it is safe to say that probably the best advice to patients is that whatever their covered share would be for laboratory testing, that will be what they'll have to pay out of pocket. Given the ever increasing amount of high deductible plans, most patients probably can expect that they'll be paying the full tilt of what the COVID testing cost would be, whether that's the over-the-counter test that they go to purchase or testing that may be done in any of our offices or certainly at any laboratory. So I think it's fair to tell there is not going to be you can get your PCR and that will be covered, but if you want to get office-based or OTC testing, you're going to pay out of pocket. It's going to be across the board. All testing is going to be at patient share or full cost if they're in a high deductible plan and that deductible. So that will be coming. As far as vaccinations, at least for now, that is still going to be governmental provided, so there will be no cost to that. But the anticipation is that there either may be the vaccine administration cost that will get passed along or some component of the drug cost itself in the not so distant future. But for now, the plan is that will still be covered under the EUA and coverage from the federal government kind of being the central repository of vaccine. So that will pretty much stay status quo. The final question that many folks have asked about is masking policies. And I will tell you, we're already, New York State has basically said that, you kind of go to what you deem appropriate, but there is still the CDC recommendation of masking, or that masking is recommended in patient care kind of areas. Folks have been asking for kind of best practices or what are other practices in the region or the network doing. I will tell you it is a very mixed bag. There is no one size fits all. I'll start from the hospital and back away from there. So from the hospital perspective, I think it is very unlikely that we will see any moving away from masking in patient care areas anytime in the near future. And in fact, I may even say that that may not happen ever, that we may never completely back away from masking in patient care areas, especially in inpatient clinical units where patients are higher risk. Now, I never say never, I never say always, but there is no discussion about that happening anytime soon. I do think, and we're already starting to see in non-clinical areas, masking has largely been abandoned, even in the hospitals. When you get into discussion about waiting rooms, hallways, draw stations, that kind of thing, I think as we get into summer and incidence continues to fall, I think it is very likely we will see further reductions in mask utilization or requirements in those spaces. Now, moving forward into what are other practices doing? There are a good number of practices, especially in the private, and I will say specialty practices in particular, that have moved to remove masking mandates in their practice altogether. And, I don't know why they feel the need to reach out and tell me that, but I've heard from many that they're doing this, over the last month has been the biggest stream that I've heard of that happening. There is no absolute requirement in the practice that you must maintain masking. I know some folks, certainly the population is becoming more, I'll say, expectant that there is not going to be masking requirements. And so all of us are seeing more pushback, whether it's in the hospital, whether it's in practices, when we are requiring masking. There is no, for all of us, we're all still private entities, so we can require whatever we want, and we can restrict service if they do not comply with those masking mandates, if the practice chooses to continue that. I don't think there's going to be an edict that comes out that you must allow for unmasking anywhere. But likewise, I don't think there's going to be a lot further guidance at this point that you must go back to masking anywhere either. So I think pretty much what we have is going to be, it's a user preference, practice-based preference. There are certainly a growing number of practices that are moving away from masking altogether. So, I think you will see patients who will come in and say, I just went and saw my ophthalmologist and they're not requiring masking. So why are you? And I think everybody kind of stands on their own 2 feet and makes this decision. I'd love to say that, there's something that we could put out or suggest. There's nothing. The CDC continues to have the recommendation. I don't see that changing anytime soon. But I think, you will have company whichever way you go. There are certainly practices that are feeling very hesitant to back away from masking. There are practices that have been waiting to unload and get rid of masking. So I think there are friends in either camp. And, I think if you look right now at incidents, Monroe County is in that kind of moderate sphere. Livingston County is in the high sphere. Most of the other counties are in the relatively low sphere, but the numbers bounce pretty significantly. I can tell you that just because I'm down at Noise most of the time now, Livingston County was low 2 weeks ago, and we're now in the high this week. So it changes fairly dramatically on a week-to-week basis. So I don't know, expecting as we get into June, July, we should see a diminution if history repeats. But there is no tried and true that, come X date, everybody's going to unmask. I don't think it's going to be quite that ubiquitous in any way, shape, or form. So with that is really all. I did see there were a few things in the chat, and also saw that some people were responding back.
So Bonnie's question about boosters for those over 65 through the fall.
Yeah, so I would say the current thought is that the currently available boosters will be the annual booster. So that bivalent booster is likely to be the booster du jour. There's not enough significant genetic drift that they're remaking the vaccine quite as quickly as they were before. And most of the guidance is moving towards an annual booster at this point. So I think there is significant recommendation that most of the population is now getting outside of their 6 months since last booster timeframe. And the anticipation is that this booster will carry us into and through the fall season, so at least the beginning of cold and flu season. So unless there's some new significant strain variant, that what we've got is what we've got. So I think now is a perfect time for those who want to get boosters. This should carry them forward for the foreseeable future. Less and less takers on vaccines and peds, so that one got answered. Beautiful. Testing of staff for symptoms. Recommended isolation if they're positive. This is tough. So, I think the problem is that the recommendation for testing of staff is going to increasingly be out of pocket, either for the practice and or hospital to pay for it, or to put the charge back onto the staff member to cover it out of their own. So people are going to actively avoid it. I do think some of the COVID pay mandates and all that are going to go away with this cessation of the public health emergency. So, I'm guessing we're going to get into this kind of flu season discussion of I don't automatically get paid and get COVID time off if I'm COVID positive, and I'm not dying and I don't want to pay out of pocket $160 to get a COVID test. So I'm just going to put my mask on, and if I'm not febrile and hacking, I'm going to go into work, and that's probably what we're going to see and deal with. So I've not heard anything about recommendations for isolation, any of that changing. I think that science has been what it is, but I think human practice is going to start intervening, and people are probably going to say, "No, I just have a cold or whatever, and I'm not paying my $200 to go and get a test to check it." And so I don't think there's going to be any one size fits all for that. Quarantine and payment going away. I do think that's going to probably subside. It would be my guess. I think there is some, Excellus had put forward some pretty good language. We can share that as to their patient responsibility plans for each of the different service lines. Obviously, it'll vary by payer and line of business, but we can certainly share that. I think everybody got or is getting a Dear Administrator letter from most of the payers saying what their intentions are. So if you haven't gotten that, you will be shortly, but we certainly can share what we have with you so that you have access to it and can see. I think that's going to be largely shared from all the payers similarly. So I'm going to shut up because there's a big agenda, and I think we've answered what's in the chat and take it from there. LJ, are you going first?
I think so. I'm looking at Jana. Renee, my next.
Well, I'd like to just tack on to Chad's statement about the end of the public health emergency before I let Elizabeth take over. We have started having conversations with the local payers about how they're handling the public health emergency unwind, and we're going to also be putting out some communications in this month's network news about what each of them is doing. The majority are working directly with practices that have large Medicaid populations to make sure that they're not significantly impacted by loss of coverages for their Medicaid patients, because this is going to be the first year in 3 years where they've had to recertify for Medicaid coverage. So we are working on that, and I just wanted to make sure I touched on that since Chad spoke to it. I will then actually, LJ, you can talk about what you've got to cover, and then we'll kick it to Elizabeth. Thank you.
My things are quite brief. I just wanted to, I'll start first by talking about a vaccination issue. I just wanted to thank Chris for responding to Toby Burchin in the chat. I think Toby's question may have been not just about COVID vaccine, but we are definitely seeing a lot more resistance and hesitancy to general pediatric vaccines, longstanding recommended vaccines, and a little less trust in medical recommendations. So the AAP has some really good materials. Jane, I can share those links as other people are speaking. I'll put them into the chat. We can share them out. But Chris, your personal offer, from your experience, I think is a great thing. And if there are other resources that Chris has to share, we'll pull those together for our teams. It's a good time to regroup around this because It would be such a shame if we have a generally under-immunized or unimmunized population of children on top of all the other hits from the pandemic. So speaking about immunizations, just wanted to alert the team that the American Cancer Society is launching a new campaign around HPV vaccination, which is essentially starting at 9. We're going to release more information about this. We're going to talk at our PCP pediatric advisory group meeting coming up. This is something that is being endorsed by organizations, including the American Academy of Pediatrics, including our Children's Hospital, many organizations in our area. But the key thing about this is there's evidence to support that this is safe and effective, more effective the earlier you give the vaccine. And secondarily, it changes the conversation because you're no longer introducing this at a time where people are considering their child's potential for becoming sexually active. It does change the conversation as it being a cancer prevention vaccine. Nothing has changed in the HEDIS requirements. I just want to make that very clear in terms of how we are being accountable for that measure, but we will share more information. And then the other thing I just wanted to mention was a thank you to practices who reached out and shared with us that there was some kind of confusing bundling that was happening around vaccines, specifically the measles, mumps, rubella, and varicella vaccine. Many of you got some notifications from Excellus that they would only be covering the MMRV bundled vaccine, the combined vaccine, and no longer individual vaccines. Because of your outreach, we were able to provide additional information to Excellus about the rationale why most practices were immunizing their first dose with the separate vaccines because of the potential risk for seizure. And that also that there were still families and children who required separate vaccines at an older age. So that has all been put aside. If you have not received communication clarifying that, there is no longer an issue about that being bundled. It should be reimbursed either way. But it's a nice example about how your personal experience shared with us allows us to get kind of into the right people at Excellus, and they made that change actually very quickly. And I think that's it for me. Am I right, Jana?
Clinical grand round.
Oh, clinical grand rounds. Yeah, so thank you. We are starting to plan our clinical grand rounds in advance. We will be doing this in the fall. So stay tuned for more information. We'll be sending out a save the date soon, so you can have it on your calendar. We're all looking again to potentially have some shared time together and then some separate pediatric, maternal, child, family health stuff and our adult topics. So if you have a particular area that you're very interested in hearing about or suggestion for us, feel free to send it along.
And Katie actually has something that she needs to do, so we're going to push her up on the agenda, and she is going to talk a bit about the changes to Medicaid prescription drug coverage.
All right, thank you, Gina. In case if any of you don't know, I'm one of the clinical pharmacists for AHP. So I'm just going to share my screen really quick and bring up. All right, can everyone see this pharmacy pearls? Very good. So last week of March, our team had put out this communication talking about the transition from the Medicaid pharmacy program is shifting who covers pharmacy benefits for patients in New York State with Medicaid. So prior to April 1st, any New York State Medicaid enrolled patient access their pharmacy benefits through their health plan rather than directly through Medicaid. So everyone was kind of managed in these managed care plans, and the state reimbursed the health plan rather than the pharmacy. After April 1st, it switched, and now New York State Medicaid enrolled patients get their prescriptions through a new program called New York RX, the Medicaid pharmacy program. So now this allows New York RX to pay pharmacies directly for medications and supplies. And so that really is the big change there. This happened because for a couple reasons that they supplied. It provides New York State full visibility into prescription drug costs, gives them more negotiation power with manufacturers, creates a single drug formulary for the whole state. There were a couple plans that are excluded from this transition. So managed long-term care plans, PACE programs, MLTC programs, essential plans, and Child Health Plus were not affected. So those people will continue to get their pharmacy benefits through their managed care plan. And so what is the role of managed care plans moving forward? They will still be responsible for providing with non-pharmacy benefits, so their medical benefits, those will not change. It's just the pharmacy benefit that's different. On here too are some resources for providers and places you can go to ask for help. So if you have policy or coverage questions, there's when this was sent, these are all hyperlinks. You can just click right on it and get to where you want to go. Provider enrollment and billing questions, you can call that number because you will, and I'm sure most are, but you have to be enrolled as a Medicaid provider in order to have people fill their prescriptions at the pharmacy. For prior authorizations, you can either call this number or there is a link here to the PA forms and references. So this is another where I would maybe save this to wherever you need, or whoever does prior authorizations for your group to be familiar with this. And then on here to the comprehensive list of the preferred drug program and all these other formularies can be accessed here. That's also going to be important because there have been changes to from what used to be covered under their managed care plan to what's covered now may be different. Also then on here is what patients need to know, what providers need to know. So I just put this patient thing here so that if people call asking questions, front end staff, anyone can really answer them so that they know what to do. This was communicated to patients through a number of letters, also text messages directly to the patients if there was a phone number on file. They do not need a new insurance card. They can use their old, managed care plan that either says Excelis or whatever they got their benefits from, or they can use their benefits card that has that CIN number on it. You can find a list of pharmacies who are enrolled here, which is the vast majority of pharmacies in New York State, and New York State is enrolled. Some specific questions about CGMs and insulin pumps are on here. The preferred CGMs can be billed through the pharmacy. Non-preferred ones would need to go through the medical benefit. They can still continue to get their medications delivered to them, and refills are still valid for up to 1 year. That's different. Before the law was only for 6 months, and now it's a year that the refills are good for. And then a number they can call if they have questions. And then the provider side of things, does this impact the value-based payment arrangements? No, they don't view this transition as being a barrier. They have a plan of delivering daily claims files and on-demand reports to the managed care plan so they can still fulfill their contractual needs. It doesn't affect practitioner administered medications or J-code drugs. There's still managed care plans are still responsible for those. Here is again the list, formulary list here, and then the OTC list here. So that's there for you. Prior auths will be honored from the managed care plan. They will carry over. Here's kind of where I want to talk a little bit more about for this transition period. So if there was a drug that they were on or any new drug, there's going to be, and it now requires prior auth or it didn't before, there will be a one-time 30-day supply that will be allowed to go through while the provider either switches therapy or does a prior auth for whatever medication that they would like. So that's what I'll talk a little bit more about in a minute. And then same things with DME supplies. They're going to be a little more relaxed during the transition period. And they're going to monitor these claims and reach out to providers to get appropriate authorizations. We weren't sure if this was going to go through, but it actually did. So this disclaimer was on the bottom in case it didn't, but it did. So I'm going to stop sharing really quick. So basically, I just wanted to go over all of that and just give a little flavor of kind of what's happened since this transition started on April 1st. We're probably going to be sending out more future communications on information as things come up or issues come up, so that you and all your staff know what to do. We're currently reviewing the impact to the prescriptions, and we'll get information out for like common medication interchanges that you might have to do over the next couple months, because like I said, the formularies are different. And if you have any further specific questions, you can email that AHP pharmacist email, and we'll definitely answer any specific questions that you might have. I know that for even just our UR pharmacies, so like Highland, South Wedge, and Strong Outpatient, within the first week alone of switching, they ended up having to generate like 700 prior authorization requests to providers, and that's just our UR pharmacies. So, just be aware that this is happening and that we will try to provide as much support as we can in terms of providing you the best information that you can either pass on to your staff or whoever handles prior authorizations, so that they know how to better handle this moving forward. I don't know if LJ or anyone else has anything to say about this.
No, thank you, Katie. I think you covered it well. Appreciate your offering the AHP pharmacist email, so that if folks are seeing, sort of common threads, barriers, concerns, I think everybody's monitoring this now.
Mm-hmm.
All the pharmacy teams, all the care teams are looking at this very closely. This is supposed to make things better ultimately for patients who are on Medicaid, but so many times when new programs are implemented, there may be actual new disparities or things that are happening that were untoward, but we need to be aware of those early, identify them and get them resolved. So thank you for your help with that.
Yes.
Thanks, Katie. And we'll re-up the pharmacy Pearl and all the information that Katie shared today in the follow-up as well. And now we will let Elizabeth do her thing, as she's going to talk about depression screening and follow-up, and then also some new tools, some new resources for our providers.
Thanks, Jana. I am going to do that, but I'm actually going to do it in the opposite order. So I'm going to share my screen really quickly. And for those of you, if there's anyone on the call that I haven't met, my name is Elizabeth Sharp. I'm the Director of Clinical Operations and Quality Improvement. And I'm going to share my screen real quick. All right. So the new tool that Jana mentioned that we wanted to, can you guys see my screen? Okay, Chad's nodding. I get a thumbs up. I got both going. The new tool that we wanted to mention is a new newsletter called the Quality Corner. So for those of you that have been with us for a little while, I'm sure you remember AHP 5 kind of fell by the wayside during the pandemic, but frankly, we had daily fireside chats, so it didn't seem quite as necessary. But we did want to have a way to bring clinical information to our network. So this is a new newsletter coming out soon. It offers a clinical focus on the quality program. So you'll notice I have some very small screenshots here, but you can see along the left-hand side, we have our quality measures listed. And we include links in this newsletter, things like quality measure definitions, updates, clinical resources, and newer relevant clinical information. So we don't just want to send out the HEDIS definitions to you. We want this to be a way to bring relevant information that ties to our quality measures. The first issue that we're sending out is going to be the lifespan. After that, we may focus on particular patient cohorts. So have a pediatric one, an adult one, potentially even focus on some specialties. So please keep your eyes peeled for that. A lot of work went into it. I really appreciate Jana's help in driving this. And we'd love any feedback as you get a chance to take a look at it. Always looking for ways to make this better. Does anybody have any questions about that? All right, I didn't really think so. I'm going to jump now to depression screen and follow-up. Everyone has been hearing me talk about this for literal years at this point, and I wanted to give you an update on where things sit. So an overview of the project, just a little bit of level setting in case folks aren't familiar, the progress that we made through the end of 2022 and our plans for 2023. So very brief level setting. For depression screening, we are working to implement universal depression screening for our patients 12 and over. What we're looking for here is that all of our patients are screened once a year using a validated tool, and that patients who screen positive for depression have an age-appropriate follow-up within a certain time frame. We have been targeting the HEDIS definitions here. So we do want the work that we're doing to align with the HEDIS definitions. This information is being communicated back out to our providers via the provider engagement report. We have not adopted the actual HEDIS quality measures in Arcadia. And there's two reasons for that. The first one is a data issue. It was challenging to fully map the data all the way through to the front end of Arcadia. And the second is benchmarks. The HEDIS benchmarks are quite high in this space. And we wanted to give folks some runway to make sure that we're doing the screenings and also that we're capturing those screenings done. So our goals for 2022 were to improve the screening rates by 15% towards the goal of 75% of all of those patients ages 12 or up. I would like to note that if you or your practice are screening more than 75% of your patients, please don't stop. We just wanted to set a nice benchmark for folks to be able to target. From a process perspective, we're looking to support our practices with workflows and other technical assistance, support the providers with the age-appropriate follow-up. The 2022 work, the provider engagement report is live. I'm sure some of you have heard about it. If not, you'll be hearing from me in the near future. It includes screening performance, results, follow-ups captured. We really wanted to get to actionable patient lists for our providers to be able to look at. So you can drill down in all these different buckets to be able to see where your patients are falling. We did a lot of continued data validation and practice engagement. And we worked on follow-up documentation. So the challenge with the definition for follow-up here, for appropriate follow-up, is really the time frame. We're looking at things like dispensed medication or an appointment with a behavioral health specialist within 30 days. And so it's possible for a PCP to do everything right, quote unquote, after a patient screens positive, refer the patient makes an appointment. But if they don't get seen for 6 weeks, you're not going to be checking that box. And so one of the things that we have done to help with that is developed a plan of care with our behavioral health integration team. It satisfies this quality measure. It actually satisfies the MIPS program as well. We have it embedded in Meta and are more than willing to talk to practices working in different EMRs if they're interested in working to get that embedded into your workflow as well. We also hired a project director of behavioral health integration. Her name is Kate Sharma, and she is kind of taking the lead for depression screening moving forward. So now for the fun stuff. I have here results from January 2021. It really should have been December 2020, but I don't have that data. So essentially, year-end 2020, we were capturing 26% of our screenings across the network. At the end of 2021, we were capturing that 41.5% of our patients had been screened. And at the end of 2022, 56.5% of our patients had screenings captured. So I'm very excited by this progress. I am going to put it into probably a graph that makes a little bit more sense in terms of looking at trending over time, but seeing that number tick up is wonderful. We anticipate that there was a fair amount of data cleanup involved in those numbers and in that progress, but that there were also some additional screenings done, additional patients, screened. For 2023, we're really focused on practice engagement. So the continued focus on screening, improving screening capture, grabbing that follow-up when it's done, and then behavioral health resources and supports. I'm going to tell you right now, I'm not going to be able to fix this single-handedly, but we know that resources are an issue here. Getting patients into behavioral health specialists is challenging. We have a depression screening toolkit, some just-in-time video modules. We have our behavioral health integration team, and we're more than happy to hear from all of you about what else you need in terms of behavioral health resources and supports. So more work to come on this, but it's been exciting to see some progress, and we just wanted to share with you that all the hard work you've been putting in over the last couple of years is really paying off. Does anyone have any questions?
There's one in the chat.
Oh, thank you.
We have many patients over age 18 who still list us as their PCP, but do not come in for yearly physicals. Seems to be counting against them in percentiles for depression screening. How can we deal with it?
Yep. So without getting too far in the weeds, one of the ways is to make sure that the patient status in your EMR is correct. So we're pulling in active patients from the Meta EMR, which I believe 12 Corners is on. And so if a patient is no longer a part of your practice and you inactivate them, that will remove them from the list. We've had similar questions with a number of our pediatricians who have parents in their charts from when their parents, when the parents were pediatrician shopping before the baby had arrived. And so noting those visits as consult only, noting the folks that age out as inactive should remove them from your patient list and from your denominator.
But likewise, you can do the telescreening if you, I mean, if they are active patients and you do, want to do those outreach visits, you still could do a telescreen and document that, and that would count.
All right, thanks, everybody.
Doesn't seem like there's any more questions. Thank you, Elizabeth. I have 3 very, very brief updates. So I think we had a packed agenda, but somehow we're still going to let you guys go a little early, I think. The first is that we are actually actively working on bringing the Well Child Roadmap to practices in Spanish. The resource has been available in English for multiple years now. And we got a request from a provider about having these in Spanish. And we said, you know what? We should have those in Spanish. So we are working with an interpreter team right now to have those translated. We will print those and we will get those out to folks who would like them. To that same note, if you are a practice who is definitely going to want these in Spanish, just send me an email so that we can be thinking about that when we go to have these printed when they're ready, so that we make sure we have enough available. Also, 2023 measures, we are trying to pin down a date for those to be loaded into Arcadia, but it's looking sometime early May to mid-May right now. So as always, we'll keep you updated as that happens. Last, there's going to be a little note in the follow-up communication today about a public health clinical grand rounds webinar next week on effective communication for providers and patients. It's one of our very own, Zipporah, from the behavioral health integration team, is going to be one of the speakers. So we're going to share that with you guys. If you would like to join, CME are available for that as well. If there are any questions, now is the time before the Church of Chad closes its doors. But otherwise, guess we'll let people go.
Does this mean I have to deliver like a homily or something, or do go forth?
I think you might.
I think you just go, yes.
I'm gonna get a whole stack of wine. We're gonna start doing communion after this. It's gonna be great.
Hey, I'm not seeing anything pop up in the chat, so. All right. As always, reach out. You know how to find us. Thank you, guys.
Thanks, everybody.
Thanks, everybody.
Bye-bye.